Good afternoon, everyone. My name is Geeraerts, and I would like to thank you for the opportunity to present my paper about work rehabilitation after minimally invasive esophagectomy. I have no conflict of interest and no disclosures. Esophageal cancer is the 8th most common cancer in the world, and it ranks 6th among the cancer-related mortality. The treatment for this cancer has become a multidisciplinary treatment where the postoperative morbidity, mortality, complications, etc. Are the most popular points of interest for studies. However, in the past decades, there is a growing attention towards work rehabilitation in cancer patients. Especially in breast and colorectal cancer, this subject has been studied, seeing as these are the largest patient groups. Returning to work may enhance a patient's quality of life and is often seen as a symbol of recovery. But little is known about work rehabilitation in esophageal cancer and has only been studied by one other group before. Our primary outcome was to investigate work rehabilitation after minimally invasive esophagectomy, and more specifically to investigate the time it takes to return to work, but also to which extent. So do patients regain their full job potential or only partially compared to their preoperative work status? Our secondary outcome was to investigate if we found any factors that might predict whether certain patients get back to work easier or faster. And the goal of all of this is to see how if we can, and how we should inform our patients on the expected postoperative course. Our patients were selected between January 2009 and April 2014 from a database gathered from 3 referral hospitals for esophageal cancer in the Netherlands. All patients had esophageal cancer and were employed preoperatively, and all patients underwent a totally minimally invasive esophagectomy, and during the follow-up period, they were disease-free. Exclusion criteria were tumor recurrence and metastatic disease during the follow-up period. Data were collected through patients' medical files, and all patients were subjected to questionnaires based on the EORTC questionnaire. And in these questionnaires, the following information was gathered. The patient's preoperative employment status and the degree of their employment, so part-time or full-time workers, if they were an employee or a self-employed worker, and if they had a blue or white-collar job, which means if they had a physically or non-physically demanding job. Other information that was inquired was the post-operative interval till full job rehabilitation, and also the degree of this, so if they only were partially or fully recovered, and if they experienced any complaints. Patients were seen during regular follow-up at 3, 6, 12, and 18 months post-operatively, and all operative procedures were totally minimally invasive, according to McEwen, Ivor-Lewis, or Oringer technique, depending on the localization of the tumor. So in our group, we have 86 patients with a mean age of 57 years, and we see that about 70% of all patients is male. Most patients are in the ASA 1 to 2 group, and about 50% has a blue-collar job versus around 40% a white-collar job. Median follow-up was 18 months, and the median hospital stay was 12 days. If we take a look at the basic characteristics, we see that more than 70% has an adenocarcinoma, and more than 60% received neoadjuvant chemoradiotherapy. We also looked at the complications that occurred according to the Clavien-Dindo classification system, and we see that most complications are grade 2, which means that they could be treated non-invasively. Here we have the main results of our study, and what we see is that at 3 months follow-up after an esophagectomy, more than 70% is non-active, with only 9% working to their full ability. At 6 months, we see progression towards working, with mainly an increase in the partially recovered group. At 1 year post-operatively, there is a further increase towards working, with 48.8% fully recovered and 28.2% partially recovered. And here, patients seem to make the leap from going from partially recovered to fully recovered. However, 30% is still non-active at that moment in time. At 18 months, we see a stagnation with only a further decrease in a partially recovered patient group towards either full recovery or being non-active. We also investigated a lot of different possible predictors that might influence the time to full recovery. But the only predictor that was found was a type of occupation, so being an employee or self-employed worker. And what we found is that a self-employed worker has a 2.5 higher chance of retaking full job potential, and they also do so faster. Another point of interest in our study was patients' complaints after this surgery, and they were asked about this during the questionnaire, what their most debilitating symptoms were that may prevent them from going back to work. And about 56% of the patients had one or more complaints, with the most common complaint being mental or physical fatigue in all three groups. And there was no significant difference between these groups, nor so for all the other complaints that we found. Oh, this one wasn't supposed to be there. And to conclude, minimally invasive esophagectomy has an impact on work rehabilitation, with about 70% of patients back at work 1 year post-operatively. However, little progression is seen after 1 year. An important predictor for work rehabilitation is being a self-employed worker, and health status does not seem to be related to work rehabilitation. Therefore, we think it's important to inform our patients about this expected post-operative course. Thank you. Are there any questions?